Well, thank you so much for this very kind introduction. I'm happy to be with you virtually. I wish I could be in Switzerland, but maybe next year. So let me just share my presentation. Okay, so I hope that you can see my presentation. I've been given the task to talk about how to select systemic therapy in HCC. And since I'm the first speaker of today's symposium, I included a brief intro slide, and the slide sums up what I hope will be one of the take-homes from today's events from you. So I would like to stress that I believe that these days, more than ever, we really need to be able to make individual treatment decisions, and that these are actually key in any stage of HCC therapy. So what I'm trying to say here in this little drawing of mine that is not that sophisticated is that I find it hard to put HCC patients really into pre-labeled boxes. And I think for each and every patient, we have to ask ourselves, what is the actually best treatment modality for our individual patient? And even if we are in the arena of palliative systemic therapies, and this would be my focus today, which therapy may be the best regimen for our individual patient? And this is so key that we include all our experts that we have in our support system into these decisions, because these decisions could always be multidisciplinary decisions. So I'm pretty sure that the majority of you are very familiar with the slide I'm showing you here. This is the BCLC staging system, and probably, very likely, actually, it's not the last time that you're seeing the slide during this symposium. And I just wanted to indicate that in the next 20 minutes or so, I will focus on these type of patients, the BCLC patients, that are the advanced stage HCC patients defined in the BCLC system by portal invasion and or extrahepatic spread, but they should still maintain a preserved liver function and be in fairly good physical condition. However, in the program, you will always have expert colleagues that will be talking about the intermediate stages and what's new in this stage, very exciting news actually, and also in the early stages. So I thought I start out with some good news first. I've here summarized the median overall survival in a lot of phase 3 trials that have been conducted in systemic HCC therapy in the past years. And I hope that you can see that the median overall survival has actually been steadily increasing, both actually in the experimental arms, which I always marked in blue, and in gray, this is the control arms. And in most cases, this is actually the sorafenib control arm. So I think there are many reasons that can explain this positive development, one being that we finally do have more effective treatment options in the first line of systemic therapy. And another important reason is that we do have options for sequential therapies. What I've marked here are the 4 trials that have actually led to EMA approvals and also FDA approvals in the first lines of systemic therapy. And here you can find the agents that are currently approved by EMA. And on the top left-hand side, sorafenib, I always call it the dinosaur of HCC therapy, because actually it's been around for quite a while. But you can see here that this was approved in 2007, and it took 11 years until finally the second tyrosine kinase inhibitor, lenvatinib, was approved on the basis of the REFLECT trial, which we will dive into on one of the next slides. And these two are basically our tyrosine kinase inhibitor options. And more recently, we have had a lot of approvals also in the space of immuno-oncology and GI cancers, especially also in HCC. And the currently approved option in our first-line therapy are atezolizumab and bevacizumab. And on the right-hand side from the Himalaya trial, durvalumab and tremelimumab, which is the first dual checkpoint inhibition to be approved by EMA. And most recently, actually, they also approved durvalumab as monotherapy. And again, I will relate to this in a little while. So if you have an HCC patient and you decide this is a patient that should receive systemic treatment, the first choice that you will basically have to make is whether you will treat this patient with a TKI, with a tyrosine kinase inhibitor, or whether you will treat him with an immuno-oncology-based strategy. So to be honest, what is a patient where I still consider TKIs to be the most appropriate choice? And this is pretty easy to say, because I usually still choose TKIs if this patient is suffering from a severe autoimmune disease or has received an essential organ transplant. And in this case, we have two options. I already named them on my previous slide, which are lenvatinib and sorafenib. And lenvatinib was actually introduced based on this pivotal trial, which was a phase 3 trial, the REFLECT trial, where lenvatinib showed non-inferiority to sorafenib. Despite the non-inferiority design, if you're looking into the clinical efficacy data, and here lenvatinib is colored in green, and the darker is the sorafenib here, you might get the impression that also lenvatinib had a bit better activity in this trial. So moving to the immunotherapy options that we have and that are currently approved by FDA and EMA, the approvals are based on these two trials. The first one being IMbrave 150 and the second one, the Himalaya trial. And in both trials, you can see that there was an anti-PD-L1 agent that was used. And in IMbrave, it was combined with a VEGF-A acting agent, which is the bevacizumab, and Himalaya used an anti-CTLA-4 agent, which means that we are here in a scenario where we can have dual checkpoint inhibition. Now, focusing on IMbrave 150, it's a pretty easy trial design. It's basically head-to-head atezolizumab and bevacizumab compared to sorafenib, and this is a regimen that's basically given to the patient every 3 weeks. For Himalaya, a little bit more complicated, and we just have to focus actually on the arms that are colored in blue. And our first focus will actually be on the ones that I circled. The first one being the maximum therapy arm in this trial, which was tremelimumab and durvalumab. And again, as a control, sorafenib was used. So if you've ever heard the term STRIDE, this regimen is also called STRIDE. And the reason why it's called STRIDE is actually that this is the abbreviation of single tremelimumab, regular interval durvalumab, and it's a regimen that's given every 4 weeks, so it's quite agreeable to the patient. So the primary endpoint of both of these phase 3 trials was, as expected, the median overall survival, and I'm showing you the this pivotal endpoint on the slide, and you can see both for Himalaya on the left-hand side and for IMbrave 150 on the right-hand side, you can see that the curves are really nicely separating also quite early on. I want to stress that both of these trials, as basically almost all other trials currently published in phase 3 first-line HCC, have been comparing the experimental arm to sorafenib, as this was the standard of care for a very long time. But there's been one trial, and I'm showing this here, so I just switched the Himalaya data to this trial. This is the LEAP-002 trial. It was a formerly negative trial, but it was one of the very few trials, actually the only phase 3 trial so far, that used lenvatinib as a control arm, as a comparator arm, and compared it to lenvatinib and on top pembrolizumab, so again, an immunotherapy combination. Again, this did not meet the predefined p-value, but I think what we've seen from this trial actually is also that with 19 months median overall survival, the control arm, meaning the TKI arm, was actually doing quite well and unexpectedly well in this scenario, and kind of establishing also lenvatinib as a drug that is still a good drug and a good option in first-line HCC. Nevertheless, I think we have to move beyond just clinical efficacy data, because we do have options in first-line therapy. And this is where we have to take, at this point, really quality of life data also into account. And what you see here are, again, for the Himalaya trial and for the IMbrave 150 trial, two graphics that show you the time to deterioration and quality of life. And the TKI, the sorafenib line, is the black one here and the red one here. And you can see that deterioration and quality of life happened sooner under the tyrosine kinase inhibitor and later in those arms that use the immunotherapy-based regimen. So basically, the immunotherapy-based combinations are also supported by these type of quality of life data. So there's a question that I'm quite frequently asked these days, and that is, how do you choose between atezolizumab, bevacizumab, and durvalumab and tremelimumab? And I think the correct answer is, I actually don't know, because we do not have any head-to-head comparisons in a randomized controlled trial setting, which we would actually need to be a little bit safer in whatever we claim here. And we need to be very careful when we're doing cross-trial comparisons, because we're looking at different trials with different patient demographics and maybe also some secular effects. if we were to do cross-trial comparisons anyways, this is how it would look like. On the left-hand side, survival, and again, IMbrave 150 in the Himalaya trial here, and the response rate for IMbrave 150 in Himalaya. You might get the impression that actually IMbrave has the higher response rate with 30% versus 20% here. However, this is actually already challenged if you compare the response rate under the sorafenib control arm with 11 versus 5%. So really hard to draw any conclusions just based on this type of clinical efficacy data. I do want to mention, however, that the IMbrave 150 trial did have a very important inclusion criterion, and that was that all of the patients were included had to undergo screening for esophageal varices, and that patients that had relevant untreated esophageal varices were actually excluded from entry into the trial. So I think one of the questions that we should ask ourselves if we have to decide whether we treat them with a atezo-bev or with durvalumab is whether anti-VEGF therapy would per se be acceptable or tolerable to our patient. And we have to take two key conditions into account here. First of all, there's the cardiovascular risk factors. So does our patient have severe uncontrolled hypertension with end organ damage? I don't mean just the regular hypertension, but really severe uncontrolled hypertension, or has the patient had any recent ischemic or hemorrhagic cardiovascular events? And in terms of bleeding risk, are there any ruptured hints of ruptured HCC, uncontrolled variceal bleeding in the past? And we may be also a little bit hesitant to give it to someone who is really high on anticoagulation. So I do want to mention that there are always from phase 3 trials a lot of patients excluded that are quite relevant for our clinical practice. However, IMbrave 150 did include about 20% of what was considered a so-called high-risk cohort. And I've marked these patients here. So this high-risk cohort was defined by main portal vein invasion, which is the VP4 status here, and or pretty high tumor burden in the liver and or invasive to the bile duct. And if you're doing a post-hoc analysis of this trial and kind of try to just look at the non-high-risk patients versus the high-risk patients, you can see that the curves are separating actually in both high-risk and non-high-risk patients quite similarly. So this means that the benefit is actually retained in the high-risk patient subgroup. However, the median overall survival is shorter, but this has to be expected because this is just simply a high-risk subgroup. So coming back to the bleeding, and if we now split our population into the non-high risk on the left side and the high risk on the right side, and ask like where actually did those bleeding events happen, we can see that the GI bleeding events basically happen in those patients with main portal vein invasion. Remember that all of these patients, of course, had received prior screening for esophageal varices. So my personal conclusion from this is that I believe that if upper endoscopy was performed and if upper endoscopy is able to rule out esophageal varices that would require treatment, and in addition, if there's no main portal vein invasion, then actually the risk of bleeding under atezo-bev is probably low. Nevertheless, we need to keep in the back of our head that upper endoscopy was actually not required in Himalaya and no bleeding events were reported. And the VP4 status, the main portal vein invasion, was excluded from Himalaya trial. But on the other hand, we do not have any hint that those with VP4 would not have benefited from Himalaya. So very recently, actually, the EMA also approved durvalumab as a mono immune checkpoint inhibition in HCC. And this was, again, an approval based on the Himalaya trial that I've showed you before. We looked at the STRIDE arm versus the sorafenib arm, and this time now looking at the durvalumab arm versus sorafenib arm. So there was a multiple testing procedure I'm going to walk you through quite briefly. So the primary endpoint, as mentioned, as we have discussed, was superiority for the STRIDE regimen versus sorafenib. This endpoint was met, and thus the EMA approval for the STRIDE regimen in February last year. But the second endpoint basically included OS non-inferiority again, so not superiority, but non-inferiority for durvalumab versus sorafenib. And again, also this endpoint was met, and hence the approval by EMA for durvalumab monotherapy. The next step was actually not met. So this is where this multiple testing ended, because superiority of durvalumab versus sorafenib could not be shown. So when are we actually deciding on durvalumab monotherapy is another of these questions that we kind of discuss quite frequently. And I'm showing you here on the left side, this is basically the cumulative overall survival data from all of the three arms. In gray or dark blue, this is the STRIDE, the durva-trema combination. In orange, you have the durvalumab monotherapy only. And again, this is sorafenib in black, that's the control arm. Just keep in the back of your head that the monotherapy was not compared to the dual therapy here. So maybe one thing where we can base our decisions on is, of course, if you look at side effect, and especially here, looking at immune-related adverse events on the left-hand side, again, in grayish blue, you have the immune-mediated adverse events that occurred under the dual checkpoint inhibition, under the STRIDE regimen, and in red, those are the side effects that occurred under just the monodurvalumab. So you can see that this is actually a lower rate of total immune-mediated side effect with monotherapy as compared to the dual checkpoint inhibition. However, looking more closely, what you can also see is that the majority of these immune-related adverse events are actually grade 1 and 2, so actually not that severe. I've talked quite a while now, so I thought we just discuss two patient cases that are fictional, but just to illustrate what we've discussed so far. Just imagine you have a 45-year-old patient with HCV cirrhosis. He's suffering from HCC, distant metastasis to the lung. He has good liver function type 2A, IB2 though, good physical condition, and he has signs of recurrent tumor bleeding. So basically, this shows you distant metastatic disease. We are in the BCIC stage. So what would be your first line choice? Would it be a tyrosine kinase inhibitor, or would you go with an immunotherapy-based regimens? So since I'm not there, I'm kind of going to discuss it by myself, but just try to make up your own mind about this question. So my first choice would actually be the immunotherapy-based regimen in this scenario. Because I think I've showed you that we have good quality of life data, and we've actually seen superiority phase 3 trials as comparison to sorafenib. And in this special case, and the reason is this hint, the signs of recurrent tumor bleeding, I would actually not go with atezo-bev, but this would be an indication for me to choose the durvalumab and tremelimumab option. And maybe another reason, but this is really some post-hoc analysis, and I think it's not that important, but I just wanted to show it to you, is this IB2 status. So if you're looking at IMbrave data, IB1 versus IB2, you can see that in IMbrave with atezo-bev, the benefit was actually just really on the side of the IB1 patient and not on the IB2 patient, whereas in Himalaya, this benefit was present in both the IB1 and IB2 scenarios. So this would basically be another potential point, but just really post-hoc data. So the second case would be a 60-year-old patient previously diagnosed with HCC back in the year within the Milan criteria, so could undergo liver transplantation. This has been 5 years ago. Graft function is quite good, and he has also diabetes mellitus and suffering from diabetic nephropathy. And now he's unfortunately diagnosed with extrahepatic recurrence. Again, the same question, what is your first line choice? Would you choose a tyrosine kinase inhibitor, or would you choose an immunotherapy-based regimen? And in that scenario, the key is really the transplantation I wanted to point you at, because immunotherapy after transplantation is still currently really a hot topic. And I think thinking about immunotherapy after transplantation, there's some key mechanistic considerations and concerns, which is first that immunotherapy may just be less effective because we have the immunosuppressant. And there's also this risk, a potential risk of graft rejection. Just how high is this risk of graft rejection? And there, thus far, only some pooled case series and single case series. And looking at one of these case series that was published 2 years ago in Liver International, looking at 52 patients with immunotherapy after transplantation, 15 of these patients actually developed acute graft rejection following immune checkpoint inhibition therapy. And every second of those 15 patients succumbed to secondary liver failure after that. There are some data that indicate, but cannot prove yet, that the longer time elapses since transplantation, probably immune checkpoint inhibitors are safer. probably have a little bit higher efficacy, but so far there's absolutely no cutoff data defined yet. So I would say that there is a substantial risk of graft rejection. And this is why in this scenario that I just tried to sketch to you, I would actually go with the option of tyrosine kinase inhibitors, merely either sorafenib or lenvatinib. So what are we taking, sorafenib or lenvatinib? Again, we can look at efficacy data, and I pointed out to you that lenvatinib has shown quite strong efficacy in the initial reflect trial and also in this LEAP study that was formally negative, of course. But of course, we also have to think about the side effect profiles. And this is the side effects from the reflect trial or snapshot from it. And you can see here that in the lenvatinib treated patients, we have a bit more proteinuria, we have a bit more hypertension than in sorafenib. And considering this diabetes mellitus and the diabetic nephropathy, this might be an argument actually to, in this scenario, choose the sorafenib over the lenvatinib. But overall, it's a very, very individual decision. So I think I have like 2 minutes, 3 minutes left. So maybe I just have a couple of slides, or just one slide basically on the question, does etiology matter? And what I'm trying to illustrate here is that this is really a hot topic that has been quite emotionally discussed on several of the past and also just on the last conference, which was the Liver Cancer Summit. And this is a nice summary, I think, of hazard ratios of all these different immunotherapy trials in HCC. And this splits up the patients into hepatitis B, hepatitis C, non-viral disease. I want to point out that non-viral disease is not a very defined population. It's kind of a mix of very different disease etiologies. But looking at this from afar, you will see that hepatitis B and hepatitis C seems to be a little more on the side of favors immunotherapy versus the hazard ratio are approaching 1 in the state of non-viral liver disease. However, a hazard ratio is, the name says it, it's a ratio, right? So let me show what I mean by this. For instance, checkmate 459, that was the monoimmunotherapy versus sorafenib. Let's look at the nivolumab immunotherapy arm in HCV, and HBV in green, and also in green in the unaffected. So the immunotherapy arm had a pretty similar median overall survival. However, looking at the control arm and sorafenib arm, you can see that there's really this increased overall survival in the sorafenib arm that's quite unexpected. But actually, this will be reflected in a hazard ratio that seems to be worse for immunotherapy. Looking at other studies like COSMIC, which was a phase 3 immunotherapy plus a tyrosine kinase inhibitor, it appears that the HBV positive patients benefit. In Himalaya, which we've discussed extensively already, it appears that HBV and non-viral patients really have a benefit of the combination therapy. So can we conclude maybe from all of these trials, looking at this data, it's actually the HCV patients that do not benefit. Let's go back to our hazard ratios here. And here in BRAVE, you can see it's especially the hepatitis C patients that seem to have a really good benefit in terms of hazard ratio from the IO combination. So I think my take home from this is that at this point, we really don't know, but it's definitely something that we need to keep investigating also in the prospective settings. So this is my last slide, just to summarize what we've discussed today, is that if you have a patient with an advanced HCC, if you're choosing the first line of systemic therapy, and if there's a contraindication for immunotherapy, I would go with TKI monotherapy. It's either lenvatinib or sorafenib. We did not really talk about second-line therapies, but I need to mention that formally all the second-line therapies that have only been tested after sorafenib in phase 3 settings. And lenvatinib, however, showed non-inferiority to sorafenib with a higher overall response rate and higher PFS rate. And then the second line, again, is not being the topic today, but we have these 3 approvals, ramucirumab, regorafenib, and cabozantinib. And the immunotherapy has evolved as the new standard of care with the 2 options, atezolizumab, bevacizumab, or durvalumab, tremelimumab, most recently also durvalumab as monotherapy. These have been EMA approved and also FDA approved. And there are some things that are under active investigation. Some of them you will listen to in the next talks, including combination of local systemic therapies, adjuvant therapies. We are thinking about immune checkpoint inhibitors beyond progression. Of course, there are new therapeutic options and new checkpoints that are under active investigation. With this, I'm at the end of my talk. Thank you very much for your attention.
Thank you very much, Anna, for this overview at all the different aspects in this systemic treatment of hepatocellular carcinoma. I would like to mention to the audience who is online that they can also put their question. There is a Slido on the screen, low on the screen, and I will have to check here if I have any question online. Not yet. And do we have any question in the room? Not yet also. Yes. Yes. Yes, I'm going. You have one? Okay.
Very important for our delegates online to use
the
microphone.
We have 100 delegates online, so it's quite important, yes.
So my name is Pompilea Radu, and I would have 2 questions. In your clinical practice, if you would have a patient with esophageal varices, grade 2, with the red spots, what would you do? Would you start immunotherapy, the combination, or would you ligate or start with, or you treat with the carvedilol, the varices?
Thank you very much. Thank you for the question. So I think it's a very important question that you're asking, because it's quite a frequent scenario. So if the patient has red spots, I do see that they are at risk of bleeding. And so in this scenario, I would actually use the option of going for dual checkpoint inhibition with the Himalaya regimen with durvalumab and tremelimumab. Before we had the approval of the dual checkpoint inhibition, when we just kind of had atezo-bev, we sometimes started with atezolizumab and hoped to be able to add bevacizumab later on if we took care of the varices. However, we all know until you get the banding done, then you have to wait a bit. And that's basically the time where you have the next CAT scan, you see the patient is progressing. So it's kind of doubtful whether you really ever get around adding the bevacizumab or not. So now we have this option, and I think this is really the typical patient where we should consider the option of durvalumab, tremelimumab if we have varices that have a risk of bleeding.
And the second question is, do you take into account ALBI score when you start a treatment? Because I see a problem with ALBI-2. ALBI-2 has a very large range. So, for example, a patient who has a bilirubin of 8 and an albumin of 31, or a bilirubin 8 and an albumin of 35, it's ALBI-2. So do you take into account?
Yes. In terms, I showed you this post hoc analysis, IB1 versus IB2. And I kind of, if I do have IB2 patients, I might have a tendency towards also using dual checkpoint inhibition and again going for durvalumab, not for atezo-bev. But I think this is not carved in stone yet, and there's no prospective data that would be really solid that I could relate to in that scenario. But liver function is such a key issue in treating HCC, because if we know that we basically, especially in the intermediate stage, this is what we always have to ask ourselves, whether we are at risk of really having liver function that may deteriorate. This is really bad, because that means that we cannot go through all the lines of systemic therapies that we have. So I think liver function, especially in the BCSCB patient, we really need to make sure that we maintain liver function, because then this gives us the opportunity to really make use of all the systemic options that we have. But if we've already arrived in systemic therapy, then at this time, I think we basically have all the choices with IB2. And I have a tendency towards the bad LB2 patient to choose durvalumab over atezo-bev. But again, this is just very personal opinion.
Okay, so you make a combination between Child-Pugh and ALBI when you take a decision.
But I do like ALBI, to be honest. But I think Child-Pugh has been on all the trials and all the previous studies. So it's something that we can relate to as hepatologists, gastroenterologists, but it's kind of subjective, right? And so I think in trials, everything should also be split up according to IB, because this is really just lab-based.
Okay, thank you.
Well, thank you very much. Thank you for answering this question, Anna. We will move to our next speakers. Thank you very much. You can stay with us if you have time.
Enjoy the symposium.
Thank you.